Today, we are excited to welcome Daniel Lettenberger-Klein. Daniel stepped into the role of President and CEO of Stella Maris in 2019, coming from the greater Atlanta area where he held various leadership roles in recovery and detox organizations. Though at the beginning of his career, Daniel hadn't intended to run a nonprofit. When he started college, he was intent on becoming a dentist. After his first organic chemistry course, however, he knew he needed to pivot and began looking at psychology and sociology so he could enter a helping profession. He graduated with a master's in marriage and family therapy and entered the social services field. Daniel has quickly grown the Stella Maris organization and is working diligently to raise awareness of addiction issues in our community and the resources available for recovery throughout his community engagement. And we are proud to call him a graduate of Leadership Cleveland class of 2022. Please welcome Daniel.
Thank you, Rachel, and thank you for having me. I don't know where that bio came from, so it made me very uncomfortable, but I appreciate it. It's nice to see so many familiar faces. Honored to be here today, and just excited to talk a little bit about Stella and just the face of addiction today. So please be thinking of questions because that makes it way more interesting at the end than hearing me talk. So excited to have you all here. First up, just a little bit about what Stella Maris is for anyone who may not be familiar. We're the oldest nonprofit drug and alcohol treatment program in the state of Ohio. We believe, we haven't seen anything to the contrary yet, the oldest sober house in the United States. We opened our doors in 1948 with 11 beds on the same block here in the West Flats in Ohio City, and have been operating consistently for 76 years. We are a bit unique in the region in that we have every level of addiction treatment on one block and as part of one continuum as we continue expansion, as we will talk more about today. And most of our clients are with us about 5 to 6 months. Of all of our outpatients, 85% of those in outpatient care live with us, which is also a very unique model. 95% of our clients are at or below the poverty line, and many are homeless at the time of admission or have been homeless recently. So it's a unique population, high risk, that we are working with every day and have for a long, long time. So a little bit about what we're growing with and where we're expanding and what we're doing. First of all, for anybody who's known Stella for some time, there is no business plan for growth. The plan for growth is how do we make sure we take care of the person at the front door? We have not been able to take care of everybody that comes to us for a long, long time. Our wait list alone for detox, which is our highest level of care, which is a medical level of care, has been triple digits for longer than I've been here, and I'll have been here 6 years in January. So we know that the need continues to hold strong. While we've seen overdose deaths drop in recently, which I'll speak to as well about why we're seeing that, some of the reasons we have behind that, but also fully transparently, we don't totally understand all the overdose death drop. But we'll speak to that. You know, us being a full continuum on one block and people being with us as long as they are, it means we're also able to treat a lot of comorbidities that other treatment centers aren't able to navigate because the amount of time people are with us. We're able to work on curing Hep C. We're able to get people started on medications for HIV and different things that some other facilities where people will come on an outpatient basis or may not be as engaged or it's court mandated, which does happen here. It's a unique opportunity for people to really be with us a long time and become a part of a therapeutic community. Our completion rates are routinely about 30% higher than national averages for every level of care. We firmly believe that's because so many people live with us and because they have just a sense of belonging and routine and structure from the moment they arrive. We take care of about 5,000 people a year right now. And that has changed dramatically over the years as well, which is why we have some of the things we're working on. Since Stella Maris was founded in 1948, we've been closely tied to the recovery community, so the 12-step AA community, which we're really proud of our role in that and how we've always had meetings and community at the center of what we do. We have 33 12-step meetings that happen on our campus every single week. So nearly 2,000 people a week that are not clients on campus just for 12-step recovery meetings. with our coffee shop, which I know the Leadership Center has comes to routinely, which we love having you there. Thank you for coming. But so about 2,000 people a week. So it's a vibrant community center for recovery and has been for some time. So for us, some of our change and transition is really related to how we conceptualize care. Some others, I see some Signature Health and Centers representation on here have done an exceptional job of really making sure that access to, and Metro Health too, that access to varied forms of treatment exists. We know that people do better after their brains have been bathed in opiates with the disease of addiction, that chronic daily use is a brain injury, that it leads to over a year of necessary healing time for a brain to overcome and heal from chronic daily use. And so kind of an old school treatment model doesn't always work. It doesn't work really well. It facilitates a lot of the white knuckling it. And we have ways that we can help people and support people that historically have not been connected with the way Stella Maris conceptualizes recovery. Being an abstinence-based model, everybody went to meetings and did abstinence-based care, and that was what we were known for and what we're still known for. But it's probably been about 5.5 years since I've been here that we've been working on making sure that we did it the right way. There's some really good medically assisted treatment happening in the community currently. But to have it happen in the continuum of Stella Maris is very nuanced. And it's been a big challenge to think through, how do we make the most impact without negatively impacting what we're known for and what has been working for us? How do we create more access, other levels of care that help more people thrive? And so for us, it's been about housing and treatment space. Those are the two things that come at a premium for us. We don't have a lot of space, and housing is always hard to come by. Every single bed, whether it's inpatient or outpatient or housing, has a wait list and always has a wait list. And so for us, housing was critical. So we're currently in the process of closing in on purchasing a property. It will be closed by the end of December. That will allow us to add 25 beds for people in what we're calling medically assisted recovery. Being involved in MAT for probably the decade before I got to Stella Maris, I didn't know anything else. I only knew medically assisted recovery in places that weren't so AA based. It was really smart recovery, young people recovery, a lot of different models. And so understanding the rich history we have with the recovery community in Cleveland meant taking our time to think through a thoughtful approach to what medically assisted treatment can look like for a community that is very tied to an abstinence-based model. And for us, that meant we needed separate housing. We could not have people on medications in the same house because if somebody knows that somebody gets something, that becomes a massive trigger and difficult thing to manage. The other was that so often we have people in treatment groups that, whether they're an MAT or not, that are getting something, and the same thing happens. When you see somebody getting onto a medically assisted treatment, very often there can be like nodding off or sleepiness or some degree of appearing euphoric. And that can also be a really big trigger for those that are not engaged or are further along in the process of medically assisted treatment. So we're also doing segregated treatment modalities as well. So group rooms will be separate for those engaging in MAT and not. So housing, treatment. And then the third pillar of it, which really we think is one of the most special components, is we have 24-hour nursing care here already. We have medication already being accessed by inpatients, outpatients, the pharmacy licensing, all of that stuff. So we're doing a largely injectable model for medically assisted recovery. Not only are we talking about medication as a recovery support, we're not talking about it as MAT, as treatment, because the medication is just like an AA meeting to us. It is an assistive support to the recovery model. And so we're trying to address the stigma even within the recovery community when it comes to medication to support recovery. So for us, if it's Advil for a headache, that's an MAR, that's a medically assisted recovery medication. If it is a sleep medicine, if it's an anxiety pill, if it's a GI medicine, whatever medication it takes to help stabilize somebody in early recovery qualifies as medically assisted recovery for us. We're trying to widen the understanding of what it looks like to be engaged in medically assisted recovery. And so we're trying to address the stigma within the recovery community, but also help people understand that medication is a part of nearly everybody's recovery journey, and we need to start shifting the narrative. So that's a big piece of it. The other is that I mentioned injectables. One of the big downsides that I've seen historically associated with some MAT programming is you don't get out of the habit of having something every day, and you're still getting that. So moving to injectables, whether it's every 2 weeks or monthly, unless there's contraindications where somebody may be triggered by a needle or other things like that, we're moving towards a model where people are not getting something every day. They're not getting a pill in hand or a film in hand. They're getting an injectable that will titrate over time, and then can still work towards abstinence if they choose to. And with that model, it allows us to avoid two things. One, they have no substance of abuse that they can walk away with. So there's no abuse potential in an injection because a nurse is doing the injection. So they can't do that themselves. And the other piece is there's no street value then associated with it as well. Historically, some other providers, some of the emergency rooms, will do a bridge prescription until they can get into their appointment. That client will maybe take their Suboxone historically or not, or take it only if they run out of their drug of choice, or they will sell the prescription or the medication to fund whatever drug they choose. And very often those clients that are not appropriately taking their Suboxone end up on our front door for detox. And the detox from Suboxone is actually far more challenging at times and complex and physically demanding than it used to be for heroin. So it's a unique presentation where we've really spent 5 years trying to build out this model that we think can help shift what medically assisted recovery can be and look like for people, while also addressing the stigma within the recovery community itself of what medications to support recovery can look like. So we think we're doing a good thing. We think we're making some good moves there. Really excited about creating the beds and access for that. And so that will be housing, treatment, and medications. All the medications will be observed from on-site on our campus. So that means no medications are in the housing either, which historically in programs I used to work in, we'd have a safe in every client's room and they'd keep their medications in their safe, and then a safe would go missing and a client would go missing and something would happen. So we're trying to do this to see if we can't have a different outcome for some of the clients that we're working with. And we're only able to take care of one for every 4 client that comes through our detox currently. So this also allows us to take care of more of those people that are asking to stay at Stella, but historically couldn't because they're using varied forms or are interested in varied forms of medically assisted treatment. And so it still allows us to work really strongly with our referral partners, but also create a different mindset internally for us. Some other things, we're expanding into Tremont, which is less than 1.5 miles away from our front door currently. Opiate settlement funding in the first and second round for Cuyahoga County went to create 32 beds for inpatient residential, which is like your traditional rehab. Most places think of a 28-day rehab. This is 30 to 45 days and is right in between the highest level of outpatient and detox, the medical level of care. So it's really neat because this level of care, we started beta testing in our former detox space in 2020. And the clients that went through inpatient residential, the identified male beds that we have, those clients that successfully completed residential had an 82% success rate in completing the full continuum, as opposed to 62% when they didn't go through inpatient residential. So it shows that the more time that we have people, the more containment and the slower we reduce that containment, people do better. There are better outcomes. So we're going to be scaling from 12 identified male beds to 35 all gender inpatient residential beds in Tremont. We have our last asks in. So if anybody wants to donate, please do. But we have our last big asks in to some of the foundations to try to close the funding gap because we had money for that. And then the pandemic happened. And the initial budget, when we went out to do our public bidding, because it has state capital dollars, the lowest budget came in $1 million over the original budget because of the construction costs during the pandemic. So we've been at it trying to raise money, trying to look at construction costs and hope they come down a little bit and see what we can do. So we're excited about that. It also came with a back house behind it. It's the former Matt Talbot Inn. So before Matt Talbot moved to Parma, they had a space in Tremont right on Professor. So we're planting an all gender inpatient residential treatment program in partnership with hopefully the LGBT Center and some other partners. to make really a fully inclusive, accessible, community steep treatment center right in the heart of Tremont. We're really excited about it. It'll have a sober house right behind it. And then we also use some opiate settlement money, not only to work on funding this house on the corner, but to buy an administrative building. We were always out of room. My office has moved multiple times. All of our offices have moved multiple times just for more treatment space. And for us, we were able to acquire a space right across the street that will be our permanent home for the admin team, but also allows us to create a donation center. We have people dropping clothes off every single day. We've never been able to take furniture or home furnishings or a microwave or plates, things like that. And we never want our clients to be going through a garbage bag in a shed to find what they need. So many of our clients come here with nothing. In detox, we give everybody scrubs just to have like a level playing field, and then we give them donations throughout. But historically, we've only been able to give clothes. So we're going to make a retail donation center in there that's no cost to any of the clients, and will be suggested donation price to alumni to be able to come back. Hopefully we can open it beyond that, but it will be volunteer led as well. And then the other side of it will give us the ability to have storage and maintenance space. We historically have never been able to do volume-based purchasing and access volume-based discounts because we just didn't have the room for it. This gives us the space to do that and build out our workforce development beyond culinary arts and barista training, because we have a coffee shop that operates 7 days a week. So have some things going on. It's an incredibly complex time for how people are showing up. We have a massive reduction in primary opiates showing up at the front door. It was 90% up until a year ago. Now it's at 34% primary opiates showing up. It's about 36% alcohol now, where it was at 9% pre-pandemic. We're also getting about 10% of people that are using alcohol and opiates, which was never a population that existed before for us. We never saw that coming to our front door. And the other percentages are really a breakdown of like crystal methamphetamine is the other primary piece, which for an organization like ours that is primary addiction treatment, but also takes care of mental health conditions, conceptualizing the psychiatric presentation for clients that are sicker for longer because of synthetic opioids, but also have psychiatric presentations that present challenges through the entire continuum, is really meant that we have to look case by case, client by client, and make sure we not only medicate appropriately, but are partnering with Signature and our other partners in the community to make sure that everybody gets adequate care regardless of where they are in the continuum, which is a very expensive thing to do. The funding model from Medicaid does not support higher acuity further on in the continuum. So us having to make those adjustments is ultimately just tied to our mission of making sure we do the right thing 100% of the time. So I hope there's some questions. I know I talk quickly, I apologize. But thank you all for having me here.
Daniel, that's great. So, and we absolutely have some questions. You mentioned a couple different levels of care throughout your remarks. How does someone identify the right level of care for them and how they're coming in, whether it's inpatient, outpatient, 12-step?
Yeah, that's a great question. So we work off of something called the American Society of Addiction Medicine. So we call it ASAM. You'll hear that referred to in addiction medicine. There's an ASAM assessment that dictates the appropriate level based on the current circumstance, what they're going through, whether that's medical, housing, food insecurity, all these different pieces and parts, relational issues, consequences, legal impacts that really help us drive where somebody needs to be. So they go through that as part of their pre-screening and when they come in to determine the appropriate level, whether that's detox, residential, partial hospitalization, intensive outpatient, non-intensive outpatient, and those are really the levels that we're looking at. We never want anyone to decide for themselves because it's just very hard to do that, and also it's a lot of people are working, so they already need some accommodation. So we have to work with everybody to also meet them where they are. So not everybody will do what they screen, what the appropriate level is.
You also referenced how kind of drug of choice or what folks are showing up addicted to has shifted. And throughout your course in this field, what shifts have you seen in that and what accounts for the shifts?
Availability and preference, cost. There's so many different factors. I mean, when I started my career in Florida when the pill mills were closing years ago, so it was a very different time. I mean, this is not a funny joke to a general population, but at Stella, we think it's funny. Like we would kill for a straight heroin addict right now. Like it would be a totally different presentation. So, Stella started on the backs of taking care of people that were struggling with alcohol. That is a very different, complex presentation with medical fragility that is just highly acute. And chronic long-term drinkers, heavy drinkers, their bodies break down, and it's really hard. And when it comes to managing withdrawal, so somebody coming off of their physical dependency on a drug or alcohol, benzodiazepines like Xanax and alcohol are the two. Benzos and alcohol are what you can die from coming off of if you don't have medical intervention in the tapering. Opiates, you typically there. This is the other reason why there's an insurance implication, and they say it's not life-threatening in the withdrawal. Opiates, people feel like they're going to die when they're withdrawing from. They die from the when they use the next time because they feel like crap. So they feel so bad that they know how to get rid of that feeling, and they use and they overdose and die. So the death potential is really typically in the relapse of the opiate use, but not in the withdrawal process. You won't die from that with opiates.
Are you seeing buy-in from residents when it comes to injectables rather than oral medication?
Yeah. Historically, injectable buprenorphine was what we used during our detox protocols. So there was um, already an injectable kind of culture in like how we did things, but we also have always done Vivitrol, which is a craving blocker, an opiate blocker that helps with cravings. Not a craving blocker, but helps with cravings as people are coming off of opiates. So yes, I think there is some tolerance with it. But that's also why we have to be really case by case and mindful of how people show up and what works for them. There are going to be people that there's just contraindications from injectables.
We've had a couple questions come in around the role of corrections and how might Stella Maris be available to provide training resources to corrections staff and just overall generally the role of corrections officers and corrections staff in helping with treatment.
Yeah, we love to meet with anybody and work with anybody to help develop and train. We've talked to some people with the jails, not necessarily on the frontline staff, but we'd be happy to work through kind of navigating those pieces and parts. I think Metro's done a really nice job of managing how correctional medicine is going to look and just behavioral health referral into the community. So I think some of those resources exist, but we're happy to partner. We've worked a lot more with like the police departments and some of the schools on how we just educate and tell parents what to look for and like help the police departments even talk to families. Because when we get there's so many Catholic schools around here that have like these positions of people just for like how to manage somebody who gets in trouble. We'll get kids that come in here that have to volunteer just because they got caught drinking. So it's like every level of intervention and education. So we're happy to help talk through and meet with anybody to talk about what might be helpful.
And the recovery process can be long and it can have setbacks and moving forward. What are some factors that may help somebody better navigate the recovery journey?
Hmm. Um, Connection is at the core of it. People have heard me say this if you've ever been here, like every chair at Stella faces another chair. That's a very intentional, thoughtful approach to people being together because nobody recovers alone, but people do use alone, right? So active addiction thrives in isolation. So the counter to that isolation and active addiction is connection and relationship. So I think having supports, building a community around you is essential. I think being a part of something matters. And so even though we operate a therapeutic community and have since like the 80s, it's an old prison model for self-governance for the clients. And so I really think that's one of the things that helps keep people tapped in. But we would say the same thing. When you have a chance to call or text, call instead of text. When you have a chance to meet in person or call on the phone, meet in person. Like the ability to stay connected to people and really out yourself routinely with addictive process. That's one of the things we talk about here. Like if you're struggling, you got to say it. We'll see it on your face. We'll say it out loud if we see it on your face or in your actions, but like leaning into where you might be at and vocalizing that vulnerability that becomes that superpower piece of like, stability is only as as constant as the bravery and the willingness and the ability to just lean in.
Curious if you have started to see an increase in people coming in due to marijuana addiction.
Um, No, I think some of our where I see it is the high potency THC is triggering psychotic features that leads to crystal meth use, and so like there's some different comorbid use patterns happening. I mean, most of our clients, many of them smoke weed, many of them don't. Our clients have a strong preference towards a substance by the time they get to us. So I haven't seen weed necessarily be the gateway drug to the harder stuff, but I do think the potency of marijuana is deeply concerning. It's not like the regular, 20 years ago, weed is totally different, than it was 20 years ago. And so people that may have a predisposition for underlying, mental health condition or things like that, we're seeing some of the mental health conditions exacerbated by high potency THC.
Outside of the treatment work of the organization, how do you step into the advocacy and awareness space to help battle some of those myths and misperceptions?
This. But yeah, I mean, Marianne has said this, for many years now, and I'm glad to see you here. Just leaders show up, like you gotta just be out front saying stuff because if like Stella, his before I got here was around like 70 something years, just with their head down doing the work, like doing incredible work on this little block. Nobody knew we were here. Nobody knew we were here unless they needed us. And so like that kind of thing of like just making sure the community knows what's happening here and how they can help and just being vocal. So showing up to the things. Leadership Cleveland was a huge deal for Stella Maris, for me. Just being able to like be in front of people and say, hey, you know what, we come see this, like come have coffee with me. I'm not an extrovert at all. It's not instinctual for me. And so like being put in a position to have to build relationship and connect, I think was really good. Yeah, I think just being very present and leaning into the stuff that's uncomfortable and going and talking and connecting.
So, talking about support of your work, there's been a few questions around the clothing donations. Can you
Hmm.
share a little bit more about what you take, when you take them? How might someone do that?
Yeah, I mean, we take pretty much everything from a clothing perspective, and then if we have overflow, we go to like Providence House or some of the other sites to drop off, and we work in partnership with all the other organizations. So it's really just at our front door. Our central intake facility takes clothing donations. We're a little unique in that we've become, uh, to some degree, the go-to LGBTQ plus treatment center for many clients in the transgender inpatient residential population we've seen just be pretty consistent over the last 4 years. So when it comes to donations, like all size matters. And so we just because we take care of a number of transgender clients as well. And so we can really only take clothes right now, but bring on whatever you got. What the best part, I love this, but like if you come down to the coffee shop on a Thursday when it's businessman's lunch or business person's lunch, and all the clients are dressed up, so you can't tell the difference between an attorney from downtown or a doctor or who are coming for a quick 12-step meeting that has over 100 people on Thursdays. You might see them in your clothes, and that's the best. Like I love seeing somebody in like my winter coat from West. It's just very cool, and like they have that moment of they know where they got it to, and it's just like it's neat.
Well, Daniel, we thank you so much for all of the work you and your amazing team are doing to address such a challenging issue in our community and continuing to raise awareness across Greater Cleveland. And thank you for being here today.
Thank you. And I'll put my email address in the or phone number in the chat if anybody wants to reach out. Happy to connect with anybody, have you out, show you around what we're doing. So thank you so much for having me here today.